Thank you. I want to pick up where my colleague, Mr. Brown, Senator Brown, left off. I want to describe one of my real patients. I won't use her name, but I want to describe one of my real patients to you. I'll call her Sheila. Sheila was 32 years old. Sheila came in with a breast mass. Examined it. I thought it was a cyst. I sent her to an ultrasound. Ultrasound confirmed the cyst. Okay? Confirmed the cyst. Did a mammogram to make sure. Mammogram says it looks like it's just a cyst. Now, the standard of care for somebody with a cyst is watch it expectantly unless it's painful, because 99% of them are just benign cysts. I had the good fortune to do a needle drainage on her cyst 3 days after she had her mammogram. Highly malignant cells within the cyst. She's since died. The reason I want to tell the story about Sheila is what the senator from Ohio, in supporting the Mikulski Amendment, what he doesn't recognize is that we don't allow the Preventive Services Task Force to set the rules and guidelines. We do something worse. We let the Secretary of HHS set the guidelines. And the people that ought to be setting the guidelines aren't the government. They're the professional societies that know the literature, that know the standard of care, that know the best practice. And in fact, the Mikulski Amendment doesn't mandate mammograms for women. It leaves it to the HRSA, the Health Resources Services Administration, who have no guidelines on it today whatsoever. So what you're saying with the Mikulski Amendment is that we want the government to once again decide. All of us are just rejecting what the Preventive Services Task Force has said, but instead we're going to shift, we're going to pivot, and we'll say we'll let the Health Services Resources Administration decide what your care should be. Now, the other aspects of the Mikulski bill, I fully agree with. I don't think there ought to be a cobay on any preventative services. I 100% agree. But the last place we ought to be making decisions about care and process and procedures is in a government agency that, number one, is going to look at cost as much as they're going to look at preventative effectiveness. And if the truth be known, the Preventative Services Task Force, from a cost standpoint, as a practicing physician, I know how to read what they put out. From a cost standpoint, is exactly right. From a clinical standpoint, they're exactly wrong. Because if you happen to be under 50 and didn't have a screening mammogram and your cancer was missed, to you, they're 100% wrong. You see, the government can't practice medicine effectively. And what we're trying to do in this bill throughout is have the government practice medicine. Whether it's the Comparative Effectiveness Panel, whether it's the Medicare Advisory Commission, what we have asked is government to make decisions. Now, let me tell you what that is. That's the government standing between me and my patient. It's denying me the ability to use my knowledge, my training, my 25 years of well-earned gray hair, and combine that with family history, social history, psychological history, family history, again, where it might be important, clinical signs, and me putting my hand on a patient like I did Sheila. For most physicians would never have stuck a needle in that cyst, and she would not have lived the 12 years that she lived. She would have lived 1 or 2. But she got 12 years of life because clinical judgment wasn't deferred or denied by a government agency. And so I'll come back. There's a wonderful member of the British Parliament. He happens to be a physician, And when we were debating the issue of the comparative effectiveness panel, which will be applied to whatever HRSA does or the Secretary does, I asked him, what about the National Institute of Comparative Effectiveness in England? And here's what he said. He says, as a physician, it ruins my relationship with my patient because no longer is my patient 100% my concern. Now my patient's 80% my concern and the government's 20% of my concern. So what I do is I take my eye off my patient 20% of the time to make sure I'm complying with what the National Institute of Comparative Effectiveness says, even if it's not in my patient's best interest. When we pass a bill that is going to subterfuge or undermine the advocacy of physicians for their patients, the wonderful health care that we have in this country is going to decline. Now, there's a lot of other things about this bill I don't agree with, but the number one thing as a practicing physician that I disagree with is the very fact. Mr. President, could I have order and ask for the people having conversation off the floor?
Chamber will come to order. Please carry your conversations off the floor.
The thing I'm most opposed to as a practicing physician, I like best practices. I use Vanderbilt's in my practice. I like them. They help me. They make me more efficient. They make me a better doctor. But they're not mandated for me when I see something that in my judgment in the art of medicine, I get to go the other way because I know it's what's best for my patient. And what we have in this bill is we have what we passed with the stimulus bill, the Comparative Effectiveness Panel, which is utilized in this bill, and we have the Medicare Advisory Commission saying we're going to cut, you got to cut. Where do we cut? Whose breast cancer screening do we cut next year? When we have the commission say we have to unless we act affirmatively another way, what we are doing is dividing the loyalty of every physician in this country away from their patient. They're no longer 100% advocate for their patient. This is a government-centered bill. It's not a patient-centered bill. So going back to the Mikulski Amendment and what's going to come with Murkowski, the Murkowski Amendment is far better. It does everything Mikulski does, but doesn't divide the loyalty or advocacy of the physician. And here's what it does. The Murkowski Amendment says nobody steps between you and your doctor. Nobody steps between you and your doctor. Not an insurance company, not Medicare, not Medicaid. And we use as a reference the professional societies in this country who do know best, whether it in mammograms, for example, whether it be the American College of Surgeons, the American College of Obstetricians and Gynecologists, or the American College of Oncology, or the American Academy of Internal Medicine, or the American College of Physicians, which have come to a consensus in terms of what best practices are, but don't mandate what will or won't be paid for when in fact the art of medicine is applied to save somebody's life, like Sheila. For you see, if this bill passed, Sheila would have lived 2 years instead of 12. 10 years was really important to her family. She got to see the children that I delivered for her grow up. One of them she got to see married. But if we decide the government's going to practice medicine, which is what this bill does, the government steps between the patient and their caregiver, deciding in Washington what we'll do, what you will have is 80% of the time good outcomes and 20% of the time disasters. That's not what we want. I don't deny there's plenty of problems in my profession in terms of not being as good as we should be, of not having our eye on the ball some of the time, of making mistakes some of the time. I don't deny that. But what I do embrace is most people who go in to the field of medicine go in for exactly the right reason, and that's to help people. And it is so ironic to me that we have a bill before us that limits and discourages and takes away the most altruistic of all efforts, which is to do 100% the best right thing for your patient. And the reason having HRSA set or the secretary set guidelines is bad is because most patients don't fit the textbook. Here's what the textbook says, but this patient has this condition, this history, and this finding that are different. So what we've done in this bill is multiple times take the learned judgment of caregivers and say you will bow to what the federal government says. You will bow to what HRSA says. You will bow to what the Secretary of HHS says. 75 times in this bill, there are new programs created. 6,950 times in this bill are requirements for the Secretary to set up new rules and regulations. If you don't think that will put the government between you and your care, you have no understanding of health care in this country. And you have no understanding of the problems that we face today because of Medicare and Medicaid rules that interrupt and limit the ability for us to care in the best way for our patients. I'm for the prevention aspects of the Mikulski Amendment. I think it's a great idea. Matter of fact, it shouldn't be just about women. It should be about screening for prostate cancer for men as well. It should be about treadmills for people with high cholesterol. It should be about true preventative measures. Now, why weren't they included? Because what we've done under the Mikulski bill is $892 million over 10 years. And we want to do this for one group, but we won't do it for the other. And if you think the government won't get in between, let me give you 3 examples right now which violates federal law today, but the Center for Medicaid Services and Medicaid Services today violates federal law. They ration the following 3 things. If, in fact, you're elderly and you have a complication with your colon, and you are a high-risk patient to have a perforation if you were to have a colonoscopy, that's when we go in with a fiber optic light to look in the colon, Medicare denies you the ability for you to have a CT, automated, camera-centered, swallowed pill colonoscopy, which is available, technologically proven, is being used outside of Medicare, but you can't have a video colonoscopy by way of a remote control camera. Now, why did CMS eliminate that? They eliminated it? It costs too much. Now, so if you're 87 years old and you've got a mass in your colon and you cannot have a regular colonoscopy, you can't even buy this procedure. It is against the law because Medicare forbids it. Number 2, and this has happened to me numerous times, women with severe osteoporosis, a loss of calcium in their bones, at 50 years of age, diagnosed with a DEXA scan, in a screening prevention so they don't get a collapsed vertebra or break a hip, you put them on a medicine. And the medicines are expensive, there's no question, but they really do work. Some medicines work for some people, other medicines work for others. Once you do a DEXA scan Under Medicare rules, you can't do another one for 2 years. So you can't check to see if the medicine's working after 6 months, to see if you see an improvement in the calcification of a woman's bones, because Medicare has said it's too expensive and we're doing too many of them. Rather than go after the fraud in DEXA scans, what they did was ration the care. So here we have a woman, you've diagnosed her properly, you've started her on a medicine, but you have to wait 2 years. And what happens during the period of time if you're given a medicine that's not working effectively, because it didn't work in her case? You have to wait 2 years, and her osteoporosis advances, and she falls and breaks her hip because the medicine you didn't, because Medicare said we're doing too many of them? Or take what CMS did to all the oncologists in this country. They said, we're paying too much money for Epigen. Epigen is an acronym for erythropoietin, which is a chemical that's kicked out by your kidneys to cause you to make red blood cells. Well, when you get chemotherapy for breast cancer or colon cancer like I've had, sometimes that chemotherapy not only kills your cancer, but it kills your blood cells. So because we were using too much Epigen, Medicare puts out a rule rationing Epigen and says unless you have a hemoglobin of X amount, you can't get a shot of Epigen. And by the way, you can't take your own money and buy it either. And the doctor will get fined if he gives it to you, if you don't meet the guideline. So what happens? For 80% of the patients, it worked fine. But for those patients who had other conditions, like congestive heart failure, or chronic obstructive pulmonary disease, emphysema, where significant drops in hemoglobin cause organ failure in other areas of the body, there was no exception made by CMS for a physician to make a judgment and saying, this rule shouldn't apply here because this patient's going to end up in the hospital. My oncologist told me of a story of one of his patients that could not get Epigen, ended up, their heart failure got exacerbated because they became anemic from the chemotherapy, ended up in a ventilator, in ICU, and died. Why'd they die? Because they got heart failure. Why'd they get heart failure? Because they got too anemic. Why'd they get too anemic? Because Medicare wouldn't allow them to give the medicine.